Hello, everybody, and welcome to this evening's edition of Clinical Nutrition. Just getting the slideshow organized here. What we are going to talk about tonight is small intestinal bacterial overgrowth. I wanted to bring this topic up as it's a fairly new topic in general in the field, and it's a pretty predominant. We're seeing large amounts of small intestinal bacteria overgrowth as a root cause for irritable bowel syndrome. And as we know, leaky gut is so connected to autoimmune disease. And we also see that small intestinal bacteria overgrowth can be a cause of leaky gut. So I wanted to make sure that we got some of the ideas around small intestinal bacteria overgrowth covered for you guys today. So we always want to, when we're talking about small intestinal bacteria overgrowth, we're going to start talking about some really technical things. And as we do, I always want to remind us to always keep in mind the basics. So keeping in mind the things that you guys have already been learning in nutrition school. And some of these basics around making sure that we're eating warm food and staying away from cold food and ice water, making sure that we're thoroughly chewing our food, making sure that we are eating our food in a very mindful way. So these types of basic things are really important to remember, because what we see sometimes as we progress into working with more complicated conditions is that it's easy for the brain to get, say, hooked onto the excitement, say, of finding new stuff on a lab. And as we do that, we can sometimes miss the fact that somebody's not getting better just because of something around the lines of basic things around chewing and food preparation, these sorts of ideas. So remembering that lack of digestive juices is often going to be a part of the problem. So oftentimes I will see people come into my clinical practice and they'll say things such as they've tried stomach acid, they've tried pancreatic enzymes, and they're not really feeling like these sorts of things have changed any of their pathology. They're not seeing any change with using those things to help their bloating or their diarrhea, their constipation. And so oftentimes those things are dismissed as they don't work. And as we go into talking about the complexity of SIBO, I just want to bring us back first to the fact that oftentimes these things, such as lack of pancreatic enzymes and lack of stomach acid, are actually part of the problem, but people aren't getting better when they take them because it's only one part of the problem. And it doesn't mean if they're not getting results that it's not something that needs to be done. It just means that it's only part of what needs to be done, and that more pieces of the problem need to be identified. So when we talk about physiology, I always like, as we're going through talking about new material, it's important to understand and go back to the basic sciences. So some of this will be review for you guys, but some of this is also to help us remind ourselves how the physiology of the body works, because that is going to inform us about how we can actually treat and progress with disease management and disease prevention and disease cure. So epithelial layer in our intestinal tract is 1 cell thick. So when we say this 1 cell thick thing, as I know you all have heard before, it's important to realize that there's many, many different layers of tissue in the intestinal tract. When we say 1 cell, we're really just talking about that epithelial cell. So that 1 cell is going to help with nutrient absorption. It's going to help nutrients move from the lumen of the small intestine into that cellular space and eventually make its way to the bloodstream. So that's a really great thing. Now, we need to remember that this 1 cell thick layer also can allow an easier entrance for pathogens. So we have mechanisms in our body to help prevent this pathogen entrance. However, if those mechanisms get, say, dismantled, pathogens can easily go through this thin layer that we see here. So the first mechanism of preventing pathogens from entering into that one-celled thick epithelial layer is secretory IgA. Now, secretory IgA is that first line defense of our body. I kind of look at it and describe it to patients as a signal to our immune system that there's an invader. So when we get say a parasite infection, the first thing that's going to happen if the parasite has made its way past our acidic stomach is that parasite's going to land in eventually our small intestine, and we will get an increase of secretory IgA from the mucus layer of our intestinal tract. And that increase is going to basically trigger the immune system. It's going to alert the immune system that there's a parasite there, and it'll basically help to rid the body of that parasite, hopefully before it even enters our body any deeper. So it's entirely possible that we can rid ourselves of the pathogens before our before our system actually even knows that they're there. There's a couple different types of A1 and A2. These aren't talked about as much. A1 to A2 ratio is going to be stronger in the regards of higher amounts of A1 in the blood. And you'll see that narrow a little bit, that ratio narrow a little bit in the gut. And that's really just because A1 and A2 target different types of pathogens. And the types of pathogens that are in the blood, A1 has a better ability to target. And in the gut, we see that A2 has a little bit better ability to target. So this mucus layer is secreted by the goblet cells. We see that secretory IgA is here, and this is that first defense to activate that immune response to get that pathogen eliminated before it gets deeper inside of our body. Now, if the pathogen gets deeper inside of our body, the second defense we have is actually the enterocytes, the cells of the small intestine in the epithelial layer. So now we're actually talking about the pathogen entering that epithelial layer, making its way across that one-cell thick layer that we spoke of earlier. Now, if that pathogen gets this far, we'll actually see in the epithelial layer, we'll actually see a release of chemokines and cytokines. And the purpose of the chemokines and cytokines is really just to trigger the rest of our immune system. So it'll actually send a signal to the monocytes, to the eosinophils, to the T lymphocytes, and it'll basically cause those white blood cells to mobilize to the area of infection. And if things are working totally correctly, then the infection will be eliminated. We also see in this layer that we have T regulatory natural killer cells. And these cells are also very important because what they're going to do is they're going to actually cause an apoptosis of infected cells. So by doing that, we start to eliminate the spread of the infection because we're basically going to cause cell death of any cells before the infection gets any further. Once we have reached a pathway where, say, the pathogen was not eliminated with that first line defense, was not eliminated with that second line of defense, now we have a third defense system. And this third defense system is done by the M cells of the small intestinal tract. And the M cells will actually phagocytize, will actually engulf the antigen of the microorganism, and they'll present the antigen to T and B cells. So the purpose of this antigen presentation is basically to have the T and B cells start breaking down and start killing the invader. One thing that's very interesting about this third defense layer is that we have this phagocytic activity. So we have this defense layer that is basically working by engulfing the antigen and pulling it into its own cell, basically pulling it away from the lumen of the intestine, and at this point pulling it closer to the blood. So this is where the challenge can lie, because we see that that different microorganisms will say take advantage of this particular function. So microorganisms that can actually piggyback and say use the M cells as a vehicle to make it further into our intestinal space, further into that cellular space, away from that lumen, closer to the bloodstream, where they can actually turn systemic. So one pathogen that we see that really takes advantage of this is the parasite Entamoeba histolytica. So it's important to realize this, because as we understand the virulence, how the pathogen takes advantage of our immune system, it, like I said earlier, it starts to inform us more of our treatment strategies. So that's the basic physiological view of the small intestine, the cells, how we actually get some of these invaders into our system, and what our immune system does to try to prevent this. So if any of those areas are broken in phase 1 or stage 1, 2, or 3, line of defense 1, 2, or 3, we're going to see that the microorganisms can make their way into our system, become more systemic, and ultimately cause more pathology. Now, we always want to remember, too, in the big picture point of view, that when we're talking about gastrointestinal illness, we're actually talking about illness that can affect the immune system, the detoxification system, the endocrine system, the brain and nervous system, as well as the skin. This is going to be really important, because when we're trying to figure out, in context of SIBO, if we want to actually look at testing and treating and helping somebody with this particular condition, we need to remember that it's not just symptoms of the gastrointestinal tract that are going to make us consider SIBO. So we can see, we already saw that with secretory IgA levels, that secretory IgA can really be closely tied with getting microorganisms and basically having those pathogens infiltrate our system. So we see that chronic stress, for example, lowers secretory IgA. That's very clear in the research, that with chronic stress, with cortisol dysregulation, we get a downregulation of the output of secretory IgA. And with that downregulation of that output, the propensity to actually have more infections contracted actually goes up. So we always want to consider the immune system's involvement there. The endocrine system is very involved, because we see that when we have infections in the small intestine, we can get an increase in an enzyme known as beta-glucuronidase. Now, beta-glucuronidase, its job is to break down the glucuronide bond of estrogen. So let me back up a little bit to explain what that means. So when we're breaking down hormones, we break down hormones by the liver. The liver helps us do that. And then the liver puts those recycled products into the bile. Now, one of the things that the liver will do when it's breaking down estrogen is it will add this bond. It's called the glucuronide bond. And that glucuronide bond holds estrogen in a certain formation that when the estrogen recycled products are put into the bile, the gallbladder contracts with the fatty meal, putting that bile into the small intestine. Because of that glucuronide bond, that those estrogen recycled products are not able to be reabsorbed into the small intestine, and they actually make their way out of our body through the stool. Now, what we see with microorganisms, with certain bacteria, is that we can actually get an increase in the beta-glucuronidase enzyme. With that increase in that beta-glucuronidase enzyme, that will actually break down the glucuronide bond that the liver added. And with the breakdown of that glucuronide bond, all of a sudden that recycled estrogen is able to be reabsorbed through the small intestine, and it does actually not make its way out through the stool. So this can cause subsequent estrogen dominance. This can cause a lot of PMS and symptoms that are associated with estrogen dominance, such as endometriosis. Can all have a GI link as part of their mechanism behind how the hormones got out of balance, and this is why. Other things to consider are the skin. There's evidence and research for sure with H. pylori and Entamoeba histolytica and those two pathogens causing skin issues, causing rashes and itching. So we always want to, when we're thinking of skin things, we always want to also consider GI pathogens. The brain and the nervous system are really important. So we know that we make 80% of serotonin and about 50% or so of dopamine in our gastrointestinal tract. Now, it doesn't appear in research at this time that those catecholamines are actually able to cross the, I should say catecholamine precursors in a way, but that the serotonin and dopamine are able to cross that blood-brain barrier and make its way to actually influence the brain. That does not seem at this point what research is saying. But we do know that one of the functions of dopamine in the periphery is actually to help regulate vascular contraction. So it actually regulates how vasoconstricted we are, how vasodilated we are. So it can affect the nervous system and the circulatory system through its ability of affecting blood flow and the vasculature. We should also consider detoxification and its connection with the gut. What's really interesting in recent research is we're actually learning about phase 3 of liver detoxification. Mostly what's being taught, I believe, at this point is just really the phase 1 and phase 2, which is a great start. And then the recent research is showing that there's also phase 3. Now, what's interesting is phase 3, in part, is actually before phase 1 and phase 2. And the first place that we'll actually see phase 3 of liver detoxification is in the gastrointestinal tract. We actually see that in the gastrointestinal tract has a particular cytochrome. It's cytochrome 3A4. And this cytochrome begins to start detoxifying things such as pharmaceutical medicine or pesticides from inorganic food. That whole process of detoxification can actually start in the gut with phase 3. And then from there, these sort of toxins can make their way to the liver to actually undergo phase 1 and phase 2, only to oftentimes further go through the rest of phase 3, which is really just described as the transport of the toxins out of the cells. So we really see that the beginnings of the detoxification for many substances begin in the gut. So if the gut's not working correctly, that alone can actually put extra pressure on the liver to try to detoxify things that are not initially started with the function from the gastrointestinal tract. So anytime, to kind of sum up this slide, anytime we're seeing immune system issues, we're seeing chronic infections, we're seeing endocrine issues, skin issues, any sort of changes in the brain, the nervous system, any changes in liver detoxification, which can look like all sorts of different things. You know, we could see brain fog, fibromyalgia, pain, chemical sensitivity, intolerance to caffeine or to alcohol. Any of these types of things are definitely going to make us think about, in part, that we need to look at the gut as one of the areas. So here are some obvious signs of gastrointestinal involvement. So remember, we're always going to consider SIBO with these obvious signs. Anytime we see gas or bloating, constipation or diarrhea, any sort of abdominal pain, if we're seeing undigested food, blood, mucus in the stool, changes in stool color, weight changes good. These are obvious symptoms that something's going on in the digestive tract. Now, if we're seeing blood, we do always want to consider things like hemorrhoids, ulcers, irritable bowel disease, and even cancer for the blood. Mucus, we're typically thinking infection is a big one. Changes in stool culture sometimes can be blood, sometimes can be bile. With SIBO, the main symptom that we almost always see is bloating, sometimes with gas, sometimes without gas. We can sometimes see SIBO with rotten egg smelling gas for certain types of SIBO. That's also a common factor. But I want to bring awareness of the fact that even though I feel, and clinically speaking, probably about 80 to 90% of my patients do have gas or bloating, that there's still a percentage of people that don't. So, you know, even though it's predominantly talked about online in the research as being something where there's these obvious symptoms, we want to make sure that we're not just assuming that it's not SIBO just because those things are not involved. And some of these non-obvious symptoms that you see here, these are really important. Autoimmunity, I want to make sure we bring awareness there, because that's where I've seen several cases of SIBO that do not have bloating or gas, and are actually, the one that I saw was extremely positive, one of the worst cases of SIBO I've seen. And for him, I initially tested for SIBO because of some autoimmune conditions. And had it not been for that, that was a huge portion of really working with this particular patient's autoimmunity. And it was amazing, off the chart SIBO, and yet not one single abdominal symptom, not one single GI symptom, perfect bowel movements every day, no gas, no bloating, no pain. So it really, this type of scenario is really important to consider, because just because somebody does not have an obvious GI symptom does not mean they don't have a GI problem. So I really want that to be one of the take-home messages from today, that anytime we're seeing any skin conditions, autoimmunity, mood changes, fatigue, female hormone imbalances, adrenals, migraines, liver issues such as chemical sensitivities, muscle pain, joint pain, any of these types of things that are not as obvious about them being gastrointestinal related and possibly SIBO related, we do always want to have that in the background of our brain, that these are areas that we really need to consider. So common gut dysfunctions when we're talking about the gastrointestinal tract to really look at. One is certainly a hiatal hernia. Hiatal hernia, there's a hiatal hernia syndrome and the hiatal hernia disease. Hiatal hernia syndrome is basically where the stomach contents come and they push up on that lower esophageal sphincter. And as they push up on that lower esophageal sphincter, what can happen is the acid from the stomach can creep up into the esophagus. And once it creeps up into the esophagus, we actually see that it can cause symptoms of GERD. Now, the next thing, the hiatal hernia disease, is we actually get the full protrusion of the stomach through the lower esophageal sphincter. So the syndrome is just where there's pressure. The full protrusion is actually where the disease is. But either way, we can have heartburn from this. Either way, this can be very, very uncomfortable. So there's a great technique you can look up online. It's called the hiatal hernia release technique. That can be a great thing to teach people how to do. It sometimes is more effective if we do that for them. Of course, you have to have a license to touch in order to do that. But if that's not in your particular scope, it's something that you can always look up online and just teach people how to do it themselves as a self-care mechanism. And for the syndrome in particular, it can really, I've seen people be able to really reset their hiatal hernia syndrome and reduce or totally eliminate their GERD symptoms just with this technique. So hypochlorhydria, so most of you probably are aware that hypochlorhydria can basically cause things like heartburn. It can delay transit time. It can affect nutrient absorption, these sorts of things. So definitely something to consider. One of the reasons why it can cause heartburn is because because stomach acid actually sends the signal to the lower esophageal sphincter that it's time to close. And with low stomach acid, what will happen is we'll eat food will come through the lower esophageal sphincter, but there won't be enough stomach acid to actually close that sphincter. And what that basically means is the little stomach acid that there is there will basically crawl back up into the esophagus and cause some of that heartburn. So always good to return to the basics of considering, is there a pancreatic enzyme deficiency? Is there biliary dysfunction? Sometimes biliary dysfunction, we need to think beyond just a give more bile or supplement a bile standpoint. Sometimes we actually have to give things, herbs called cholagogues, that will actually help with the gallbladder contraction. Bitters will also do that as well. It's also important to remember that things like arsenic and toxic metals can shut down a protein in the gallbladder known as the MRP2 protein. Now, when the MRP2 protein is shut down, biliary production or biliary function declines. So we're unable to secrete bile or the toxins. So it's really, really important too to consider, does somebody have heavy metals as a reason why they're possibly not having gastrointestinal health. And this is another area where we're seeing that liver toxicity, that liver function is directly related to GI function. So we always want to consider leaky gut. And at this point, I pretty much assume that if people have leaky gut, or if people have pathogens or pathogens such as parasites or bacteria, or even GI viruses, that they have leaky gut. We do use in clinical practice, we do use a great test called the Wheat Zoomer by Vibrant America, which looks at all different markers for wheat. It's the best wheat test I've ever seen. It looks at 114,000, I believe, is the number of different markers for wheat. I have actually recently contacted the company to verify that number. But it is something close to that. So it's amazing how many different ways they test for wheat. And they also test for zonulin, for LPS, for actin, for myosin, for all the tight junction proteins. So we can actually see if there's leaky gut and measure our progress with that test. And that company was Vibrant America. And as nutritionists, you are able to get accounts with them. You can't legally run anything through insurance with them, but you can get an account and have people cash pay if you are interested in lab testing and using them as a way of measuring your progress. So other things to always consider are food sensitivities and allergies. Typically see that food sensitivities tend to be more of a result of leaky gut than a cause. When we have leaky gut, what happens is food particles end up going through the intestinal barrier, going through those tight junctions when they're not fully broken down, and they end up in our blood as too whole of foods, and our immune system does not recognize them, and so it starts tagging them as invaders. And so usually it's the sensitivities that are really coming out of as a result of the leaky gut, and it's not the other way around, which I sometimes see to be misunderstood. And I see this all the time in clinical practice, where if we can just heal that leaky gut, the food sensitivities go away on their own. So I don't typically recommend for anybody to do any food sensitivity until very late in a treatment process, because oftentimes in the beginning, people are going to be sensitive to so many foods, and it can be so challenging to get people off so many things. When we can just go in and fix the gut, most of the time when I fix the gut, then I go and if I decide to do food sensitivity testing, which I only tend to do if people are tend to be, just asking for it, just want to know if there's anything they're pretty sensitive to. And most of the time at that point, once we've done all the GI work, people tend to be only sensitive to just 1, 2, or 3 foods. So it makes it a pretty minimal elimination process for them. We always want to consider malabsorption, that we're not absorbing nutrients correctly, and that's contributing to any overall health picture. And then of course, like we're talking about in this discussion, dysbiosis. So by dysbiosis, we can mean having a lack of good bacteria. There's a problem with the microbiome. It can also mean that we have a pathogen that has invaded our intestinal tract, and hopefully not become systemic. So is there a party in your gut? So that's where we're going now. So essentially, SIBO is a party. SIBO is a fermentation party. When we have SIBO, we're basically having all of these bacteria. When we feed them, they ferment and essentially create a brewery, which is why there's so much bloating and gas, is because of all the fermentation process from these small intestinal bacteria. Another thing to mention here around just even talking about asking people if they're bloated, that I just want to bring up, is that a lot of people do not have a concept of what bloating is. A lot of times I've realized that when I ask people if they're bloated, they're telling me actually they don't realize that that's an intestinal, abdominal symptom. So oftentimes I have elicited that people, when they hear the word bloated, they think that bloating means edema. So they're getting perhaps swelling of their hands, of their ankles, And with that swelling, they're calling it bloating. So it's really important when we're trying to elicit that symptom that we're really explaining to people what bloating is, that you feel that after you eat, the abdomen swells and it's uncomfortable. A lot of people too have had SIBO for so long and are so bloated that they don't actually know what it feels like to not be bloated. So that's another important thing to realize, that even if we ask people if they're bloated and we remind them and we tell them that it's in their abdomen we're talking about, they might not understand that. So questions that you can use to elicit what you're looking for here are, do you notice that after you eat, you feel like you have to unbutton your pants? Or do you feel like the pants that you put on in the morning at the end of the day are actually not very comfortable anymore? Another one is, if you have to bend down to tie your shoe or pick something up off the floor after a meal, do you ever notice that that puts pressure on your abdomen and hurts? So these are good questions that can really, if people are having a difficult time, and if people, you ask if they're bloated in their abdomen and they say no, I always follow it with these types of questions so that I know that I'm actually truly getting the information that I am looking for. So why are we talking about SIBO? Why did I bring this to the table as a point of discussion tonight, and as an addition to what you guys are already learning in this particular class? So the main reason is because the testing is really important. If there's 70% of those with IBS have been shown to have a positive breath test. Now, the breath test we'll get to in a few minutes, and it is the way that is the most common way in the field for diagnosing SIBO at this point. So we have the SIBO, this diagnostic test for SIBO, and 70% with IBS are positive. And for the longest time, in the conventional medical world, we've thought that we don't know the cause of IBS. And here we have this great statistics that's saying that SIBO is one of the main reasons. So SIBO can also lead to subsequent leaky gut. This is another big important thing, because as we know, with leaky gut, we can develop food sensitivities. With leaky gut, we can get malabsorption. With leaky gut, we can get autoimmune issues. Autoimmune issues are usually a triad of a genetic predisposition and an environmental trigger that turns on that gene, and thirdly, leaky gut. So always want to come back to things like SIBO when we're considering a leaky gut picture. And SIBO can be caused by food poisoning and or abdominal surgeries. And always remember, cesarean sections are an abdominal surgery. So food poisoning is pretty common. Cesarean sections are pretty common. So that's basically telling us that the causes of SIBO are actually pretty common. So we can see why it's such a predominant thing. So looking at some of the root causes of SIBO, food poisoning, what it will do is it will release a toxin, and this toxin is going to it's going to cause a autoimmune type of reaction. So there is an autoimmune component to SIBO, and that autoimmune reaction is going to damage the nervous system. It's going to damage something known as the migrating motor complex. And the migrating motor complex, its job is to contract about every 90 minutes to 2 hours while we are in a fasting state. So this is not the contractibility of peristalsis. This is not the segmentation that we learned about in school that propels, that churns food and propels food through the digestive tract. We're actually talking about a different mechanism here. And the point of the migrating motor complex in this fasting state is to basically move out food and to move out leftover food particles and really debris, really trash that's kind of been left in the intestinal tract after the food has moved through. So in situations like SIBO, what can happen if we've had food poisoning is the normal flora of the intestinal tract of the large intestine can crawl up to the small intestine, which does have some microorganisms, but is generally relatively sterile in comparison to the large intestine. And once these microorganisms get there, if the food poisoning thing has happened and the migrating motor complex is turned off due to that toxin's effects on the migrating motor complex nervous system component, then the migrating motor complex will turn off. And the migrating motor complex will not be able to basically do that contractibility during that fasting state. So if there's no contractibility during that fasting state, all those microorganisms that have crawled from the large intestine to the small intestine are stuck, they're trapped, they can't get out. And that's where we get the fermentation happening and the proliferation of the microbes, and then basically creating the brewery that I just mentioned, is because they're now in the small intestine and the migrating motor complex is not able to get them out. So other things that can affect SIBO is hypochlorhydria. So hypochlorhydria is going to allow microbes to cross that stomach acid barrier. It's going to allow microbes to get into the small intestine. And once again, without that migrating motor complex, they're not going to be able to get out as easily. Other things we should consider are any sort of causes of dysbiosis. So any sort of abnormalities in the microbiome, such as things such as too many antibiotics, poor diet, hygiene problems, cesarean section versus a vaginal birth. So anything that's going to change our own intestinal microbiome can set us up to a scenario where SIBO is more likely. And then, as I mentioned too, we also do see in the research that abdominal surgeries do increase the likelihood of SIBO. So anything that where we're really opening up the abdomen, I'm not sure that's something as simple as, say, like a laparoscopy type of surgery would be enough to do it. But any more major surgeries for sure, where we are basically cutting into layers of the abdomen and the muscles there, can definitely affect the small intestine. So we're going to test when we're going to have common symptoms of SIBO. We're going to consider testing when we have any of the areas that we talked about before, where there's an immune system dysfunction, there's a hormonal dysfunction, there's a detoxification issue, any of the other symptoms we talked about around migraines, chemical sensitivities, female hormone imbalances, skin issues. We're going to be thinking of all of those. The big ones, though, are any of these common symptoms, autoimmune diagnosis, and history of food poisoning. So if we see any of these things, gas, bloating, diarrhea, constipation, autoimmunity of any kind, no matter where the autoimmune condition is occurring in the body, and anybody that's mentioning food poisoning, it's just an automatic test. And then for some of those other symptoms that we talked about, we do want to be considering SIBO. We may or may not test that depending upon what other obvious things are coming up with female hormone imbalance. We can always, if they're not having GI symptoms and we want to not run a bazillion tests at once, I might tend to do something like work on the adrenals, work on the overall hormone balance, get out any sort of xenoestrogens, make sure the liver is working well, see where that takes us. And if I get stuck, then maybe come back and look at SIBO. But with any of those symptoms already mentioned earlier, we're talking about common and not common symptoms, obvious and not obvious symptoms, we are always going to be wanting to think about SIBO in the back of our brain. It's just what you see here on this slide. These are the ones that when you see these things, always just go ahead and test somebody. As nutritionists, you can use tests from Commonwealth Labs. BioHealth Labs will work with nutritionists. The other places that you can do is you can just get an account or go onto Direct Labs and use, like Genova has a good SIBO breath test. But if you want a direct account with a company, BioHealth Labs is a good one that works with nutritionists. So we just want to use the lactulose breath test. There are some companies out there that are using a glucose test. Lactulose is important to use because it's not well absorbed in the stomach or small intestine. So it's going to make its way throughout the entire small intestine, which is really important because the lactulose basically is going to feed the SIBO if it's there. And that SIBO, when we feed it, it's going to gas. And how the test works is it's a breath test. So once the SIBO is fed, the patient would basically collect the gas in tubes, send that to the lab, and that would be analyzed. Now, somebody could have SIBO, say, simply in the terminal ileum, but not in the duodenum or jejunum. And so it's really important that lactulose is making its way all the way throughout the small intestine. Otherwise, we could get a false negative. So some testing mechanisms out there will use glucose, and I want to advise you guys against that. The reason for this is because glucose is going to be absorbed. It's not going to make its way all the way to the terminal ileum, and we could have some false negatives. So we could miss some of that lower intestinal pathogen, or that lower intestinal overgrowth. Other things to know is this will be always included if you guys decide to start ordering these labs. You'll always see information about how to properly prepare for testing. This is really important that we talk to our clients about, because the testing prior to actually doing SIBO is really, really strange. And I say it's strange because what they have to do is they have to take all the fiber out of their diet. And the reason for this is because fiber naturally will make us produce some gas. And if people are eating different amounts of gas, it does not help us establish a proper baseline for actually if they have SIBO or not. So that baseline is going to be really important. So the instructions are always in these kits about what people need to eat. It's going to be really simple stuff, such as a lot of white rice, a lot of chicken, very, very bland foods. There are a few vegetables, such as, I believe, cucumbers are on there. So there's a couple like non-fibrous-y vegetables that people can have. But that's pretty much it. It's a pretty boring diet, and they eat it. The test will recommend to eat the diet for about 36 hours. The other point to make you guys aware of is if people have slow transit time, if they are constipated, they actually do need to do that prep diet for closer to 48 hours. So you do want them to do it for 2 full days. That's going to also help since they have a slower transit time, it's going to help get some of the old fibers out that could still be kind of brewing and fermenting in their intestinal tract to, again, help reestablish a good baseline. And a common patient testing error I see in practice too is when people don't collect the breath right. And that just really comes when people are breathing in the tube, and before they pull the tube out of their mouth, they start inhaling. So the thing to always instruct people on, and this will make more sense if you actually decide to start testing SIBO, and I recommend that if you do, even if you don't have any of these symptoms, order one for yourself, at least walk yourself, at least pretend like you're taking the test, even if you don't decide to, say, turn it in and get it run, so you can have a sense for what I'm talking about here. But what I'm saying is when you actually have the test tube up to one's mouth to basically collect the breath and you're exhaling, what can happen is if you start to inhale while that tube is still up to your mouth, that will suck in all the atmosphere, all the room air, and it'll actually contaminate the sample. So it's really, really important that the breath, that when somebody is, say, breathing into that tube, that the tube is fully far away from their mouth before that inhale is taken, and this will prevent some testing errors. So when we get the results back and we're actually looking at them, you're going to see a graph that looks like this. And I'm going to advise you to never read this graph, because this graph is not very, it just really does not help with the interpretation of the results. What we need to actually look at is this graph here. We're actually seeing the numbers. We're going to analyze methane and SIBO separately. So we don't have a lot of time tonight to go into the actual testing for this. There's definitely, I do offer some courses where if you are interested in learning more and getting CEUs, I do have a course on my website where it goes further into some of the testing mechanism here that could be helpful for you. If you just want to further your education there, the CEUs totally are qualified for NANP credit. So, I'm sorry, I actually realized they're not actually qualified for SIBO, just some of my other classes, but there are still classes online for for our NANP credits. And if not, you can just do the SIBO without the NANP credits if you want to know more about how to diagnose this and be comfortable with the labs. But just to give you a basic overview here, we see that methane, anything for methane that is a 3 or more plus the symptom of constipation is going to be a positive. Hydrogen, we're going to completely analyze that differently. So this one we see at the 20-minute mark, at the 60-minute mark, at the 90-minute mark, we see 3s, plus this patient had constipation. This is actually going to be a positive test. This is a SIBO positive test. But when we look at that, we look at this graph here, and when we look at the increase, these two things on the right, the increase over baseline and the baseline elevation, they actually look normal. That's why this graph that's actually mapped out here is not a very good way of analyzing it, because if we look at that, we're going to say this is a normal test when this is actually a positive methane SIBO test. So methane tends to be seen with constipation versus the hydrogen type of gas is seen more with diarrhea. There are some tests out there that are being done at clinical offices that are not always even looked at for methane. Some testing companies are just looking for hydrogen. So always make sure you get one that's looking for hydrogen and methane. Here's another methane. We see this person is very clearly positive. So lots of things that are well over 3, plus the symptom of constipation there. Methane's not always going to be seen with constipation. It usually is seen with constipation, but it's not always seen that way. So hydrogen, we're going to basically analyze the baseline. So the baseline is going to help us analyze how good of preparation diet they did. If they did a good preparation diet, we're really going to look for a baseline that's 6 or less. So anything greater than 6 is basically telling us that prep diet, the diet I told you about with white rice and chicken and these sorts of things, was actually not, very good. Depending upon how high above, let's say, a poor prep diet, these numbers, these values would depend upon if this person has SIBO. But this person has a 56, a 38, a 37. So this is also going to be a positive SIBO test. If in certain cases, the preparation diet is so skewed that it really can affect interpreting these values. If that's the case, sometimes we will have to have people actually repeat their SIBO lab because this preparation diet is so crucial. And then, like I said, like typically hydrogen gas is going to be seen with diarrhea. And then it's also going to see with people not tolerating certain carbs, beans, high fiber food. We're also going to see that a lot of times with methane gas as well. So the other thing that's very interesting from a lab testing perspective is this third type of gas called hydrogen sulfide. Now, there's not a lab on the market right now which is testing for this third type of gas, but there's a way we can extrapolate the data from the actual hydrogen levels. So that's another important thing to realize, that if we don't know how to interpret this hydrogen sulfide, then we could get some false negatives. So with the hydrogen sulfide gas, we actually have a rotten egg smelling gas. So if people are coming in and you're talking about their flatulence, always ask them like what the smell is, and particularly ask them if it smells like rotten egg. If it smells like rotten egg, that should be a keynote for you to really consider this hydrogen sulfide type of SIBO. So all hydrogen values across the board are 0s, 1s, or 2s. If that's the case, then the hydrogen is likely converted to hydrogen sulfide. So when we're looking back here at this hydrogen lab, if all of these values, the 9, the 7, the 17, the 37, 56, and 38, of all of them were 0s, 1s, and 2s, that would make us think that this person had SIBO, especially if they had sulfur-smelling gas. So we see that here in this particular lab. We see 2, 0, 2, 2, 2, 0. So this person is somebody that we're probably going to want to treat for SIBO. Another thing to know about SIBO is that it has a high rate of recurrence. So after we treat it, we need to test it. We may need to make sure it's really gone. there's definitely been several times where people feel so significantly better, but it's not all the way gone. When we test, that's really important to know, because otherwise they're just going to start having their bowels increase again, their symptoms increase again. And then it's also going to be really important that we do something post-treatment to heal the leaky gut, as well as to get that migrating motor complex working again, because getting that migrating motor complex working helps to prevent recurrence. I imagine you guys have seen the Bristol stool chart. I always use this as a way of tracking progress and analyzing where people are. Oftentimes people will consider type 1 or type 2 as being normal, and of course we know that that person is actually pretty constipated. So we really want to get people in, the type 3 and even preferably the type 4 to really know that they are actually moving their bowels in a very proper way. So that is our goal there. Treatment-wise, from a dietary perspective, as nutritionists, I generally use a combination of the SCD with low FODMAPs. Alison Seebecker, who is a predominant leader in the SIBO field, she has a great food handout on her website. So that's Alison Seebecker. You just Google her and SIBO food treatment, you'll find her handout. And that's what I generally use. You'll see that the list is color-coded. You see that it combines SCD with low FODMAPs. And when you see it color-coded, it's color-coded green, yellow, orange, and red, with green being the foods that are going to exacerbate the SIBO the least, and red being the foods that are going to exacerbate the SIBO the most. Now, there's research that I have on here where I say research about guar gum and SIBO treatment. That research is basically done by looking at two groups of people that both had SIBO that were treated with the same antibiotic, with Xifaxan, and one group was actually given guar gum, which is a SIBO no-no, and the other group was not. And what this study found was that the group that was given the guar gum actually performed better on the study than the group that was not. So what this basically tells us is that the likelihood of people having the people actually contracting, that the people actually healing from SIBO is a lot better if perhaps we can feed it a little bit. The idea is that perhaps it's coming out of hiding, and by coming out of hiding to eat the small amount of food, then our immune system has a better ability to actually fight it. So because of that research, what I recommend is I show people this handout and I tell them to stick to the foods in the green, the yellow, the orange foods, or the green, the yellow, the orange columns, and then to just have one serving, one cheat in the red column per day. And people do really well on this. And the other great thing is it's not overly restrictive, where it still allows a great deal of compliance. And usually I tend to treat people for about 2 months. So herbs, there was research showing that herbal treatment for SIBO was more effective than antibiotic treatment. So I believe herbs in this study performed, I think, something like 11 or 12% better. So I always start with herbs in my practice, and I move on to referring people to antibiotics if they're not getting results and if we can't get things to switch around. And I think at this point, I've only had to do that 3 times. So it's been very, very rare that I've actually had to refer somebody for antibiotics. But certainly there has been a few times where, for whatever reason, people just do not respond as well to the herbs, although 95% of the time I find them to be extremely effective. Never seen that the diet alone resolves SIBO. Research has also shown that the diet alone is not going to be resolved SIBO unless we're talking about the elemental diet. The elemental diet has been very well researched for SIBO, and Integrative Therapeutics company has now come out with a new powdered elemental diet formula. So that's also a great help if we want to stick people on the elemental diet, but it's a hard thing for them to deal with the preparation component of it. Integrative Therapeutics has a product that people can do that diet for. So, but if it's not the elemental diet, if we're just going to stick people on like SCD or FODMAPs or a combination, that tends to alleviate a lot of the symptoms, but doesn't actually tend to fix the problem. So overgrowth-wise, we see that the migrating motor complex is something to always come back to. So the migrating motor complex, remember, if we don't fix that, the likelihood of reoccurrence is very, very high. One of the easiest things to do is help people make sure they're fasting as long as their blood sugar is okay, making sure they're fasting at least 4 to 5 hours between meals. Also consider intermittent fasting if their blood sugar is stable enough. So with intermittent fasting, if we can get people to not eat for 14, 16, and even up to 18 hours at a time. So doing something like eating an early dinner one day and skipping the breakfast the next, that can really help the migrating motor complex. So that can often be a great thing to do a couple times a week for people, if, of course, their blood sugar is stabilized. We do want to always address thyroid and the nervous system, as we know that helps with gastrointestinal health and contractibility in general. Although the vagus, it's important to realize that the vagus nerve does not innervate the migrating motor complex of the small intestine. It does innervate the migrating motor complex of the stomach, but it doesn't do the small intestine. So that means that all these things that are going to upregulate the vagus nerve, and really some of these parasympathetic type of activities, while they're great for digestion, they're not actually going to change the migrating motor complex, which is why fasting is so important. So the last thing I'll just mention today is just, we always want to consider things such as mind root causes. We always want to be asking our clients what their process is around digesting life. Are they resisting life? Are they able to move through life and, say, chew through the challenge of the day? Are they getting nervous when something's troubling? Do troubling things make them want to vomit? Like how much is the mind playing in to what is happening with their digestive process? And although most of us are not therapists and we're not going to work with people as far as doing any sort of trauma work and revisiting past experiences, that's not in our scope. What is in our scope is helping remind people, that they can breathe when they eat, and helping with people to, if they're getting a little dysregulated and they're having intensity occurring, perhaps that's happening because they have some sort of belief about what's going to happen in their day, and they have some sort of fear about their past or their future. And what we can work on, what is in our scope, is helping people find better thoughts and beliefs to start reprogramming their brain with and start thinking about more, so that they're having a ability to digest just the overall experience from life. So thank you all so much for participating. And this is Dr. Diane here, and we will talk to you real soon. Take care.